Ray and Glaze Parker. I am the Women's Treatment Coordinator for the Department of Behavioral Health and Developmental Disabilities. And what that means is that I have the privilege and I'm honored to provide some oversight and support and technical assistance and funding to our gender-specific programs. You know what? I think he's got the wrong title, but that's okay. We're gonna roll with it.
Is this the wrong slides?
I hope not.
I have, so if it is, tell me, because I have the other version too pulled up, so I can pull up that one if that's what you're wanting to go.
Can you pull up the other one and make sure?
Yes.
I feel like these are. You know what? We're going to roll with it. Okay. Is that the second one that I sent you?
This is the first one. The other one I had pulled up was the second. So
okay, pull the second one up. Well, I'll just roll with it.
Okay.
As long as I can see it, that's good. Okay.
This will be the second one.
Okay. So, and the reason why yeah, this isn't the right one.
Okay.
I'm sorry.
That's okay.
Can I send it to you?
You can, yes.
Sorry. While I'm doing that, I'm going to try to keep talking. So my role at DBHCD is to provide some oversight and technical assistance to the women's treatment programs in Georgia. I'm also a person in long-term recovery, and what that means for me is I haven't felt the need to use any substances in over 17 years. The reason why I guess I consider myself to be, this is not just my passion and my work, it's a personal journey. So I started this work long time ago, but how it began was I was pregnant, I was using substances, and I went into the ER to get some help. When I went into the ER, I had no idea what that meant. I just knew that I needed some help and that I had just found out that I was pregnant. The emergency room actually turned me away, told me that I was kind of a liability, and gave me some information to the local health department and kind of said good luck with that. That did not end well. I hope you got it now.
I continue. There's a slight delay, so I think it'll come through in a second.
Okay. I continued to use, and when my son was born, I got child services in my life, which at the time was terrifying, but it was also a blessing. I went into a women's treatment program, actually one of the ones that I now manage, and got to bring my son with me, got to have him there, and realized the support and that recovery was real. And for the first time in my life, I saw a little hope. After that, I graduated that program and decided to go back to school for a really long time. That's all those initials after my name just mean student loan, student loan, student loan. And so now I'm a licensed therapist. I'm a master addiction counselor. I'm also a certified addiction recovery empowerment specialist, which is the CARES, which is our certified peer specialist here in the state. So it's been a really cool and interesting journey. A couple of things that I really touch on the most that are really important to me because of my lived experience and also because of the work that I do now is that we really need to work on recovery messaging and the way that we approach people, not just in a trauma-informed care way, which is kind of the term that we're all used to, but in a way that is treating people with the dignity and respect that they deserve. Okay, you can go. The language really matters. William White was a recovery advocate, and he This is not new stuff. He had written a lot of what we call white papers, did a lot of research around recovery-oriented systems of care, really dug deep into how messaging and how language matters. So he is one of my personal mentors and has really done a lot of work in this. But it says that our words carry a message of hope, and they should, no matter where we sit. Patience. So this is Georgia's definition of recovery. I'm not going to go too far into this, just as effort of time. I'm going to make sure that you get these slides if you want them. But Georgia went through a lot of listening sessions and focus groups trying to put language and definition to recovery because it wasn't so easy to define. It's unique to each person. It's personal. It's not something that our systems are going to give away as a gift. It's relationships, it's environment, it's all those things for that person, but it's really our responsibility, and it is everyone's right to pursue recovery in the way that they want to, okay? So the words that we use are important, and this is something that I found really interesting because in our provider network with substance use treatment, recovery is just kind of our second language. But what I have found in working across systems is that the language changes a little bit. You hear differences in the medical community and the criminal justice community. You just hear a lot of differences in language, but we're really all talking about the same thing. So why not put a focus on recovery and a message of hope? It should be respectful. It should be clear and understandable. We in the provider behavioral health are really bad about talking about diagnosis and symptoms, and you're a client and you're a consumer, and it's confusing. And why can't we just say it with a sense of non-judgmental and a sense of hope and some unity? Okay? I call this unicorns and Bigfoot just because they're myths, and these are things that we should take out of our language, that once an addict alcoholic, always an addict alcoholic. That is not true. There is many treatments that can change the way that people's brains have been changed, and so neuropharmacological, there's a lot of changes that happen within the brain during addiction. The same changes or different changes also happen during recovery. When I was in my active addiction, I was very violent, very reactive, not a very nice person, and I have retrained my brain to think and react in new, different ways. So I'm not an addict. I have a new brain. It's fully recovered, and so I'm not going to walk around and say I'm an addict. Saying that someone is an addict has a negative connotation to it, and when people hear that, they automatically think, oh, they're still using or they're still this. But really, a person in recovery is a better way to put that, or someone struggling with addiction. Another myth is that you can't do anything for someone suffering. I would say that everyone has to do something. This is everyone's responsibility. Our communities are being hurt. This is in your neighborhood, in your kids' schools. It is everyone's responsibility to make sure that we are engaging people. And the way that we can do that is just to approach them like human beings, okay? So another thing that's really kind of hot, and we've done a lot of work around here lately, is that people living with mental health challenges are violent and unpredictable. That's really not the case. In fact, most people that have mental health challenges are going to be a victim before they'll be the perpetrator. Violence is not a diagnosis, and so we really try to advocate and reduce that stigma that mentally ill people are not typically violent. Babies born with neonatal absence syndrome are addicts. I want to say that this is my pet peeve. I hear it all the time, especially in child welfare systems where we call them drug babies or crack babies or whatever the new, the new word is. But addiction is a brain disorder. It's also a behavior condition where someone's life has kind of encompassed around those behaviors and that lifestyle. So babies are born dependent on a substance. They're not drug babies. They're not addicts. Okay? So we have to change these myths just amongst ourselves and also in the community. The most judgmental group of people sometimes that I have found are people actually in recovery, and we like to judge each other. But I do think that most of the time it just takes a, hey, you know, let's say it like this instead of like that. And it starts with the system and the professionals in that system. Okay? So here's some do's and don'ts, and this is not necessarily, a lot of this is, yes, it is the way I feel, but don't say he or she is an addict, or don't make them say it either. Don't equate their identity with a diagnosis. The term is a person living with a mental health challenge, living with an addiction, or living with a substance use disorder. Don't share false statistics. We often tell people that recidivism in programs and relapse is going to happen, and that's not necessarily true. There's around 23 million people in this country that are still struggling with addiction, but there's also 25 million people that are in long-term recovery. And so we skew that just based off of certain sample populations, so it's really not entirely true. Don't ask people what's wrong with them. Instead ask what's happened to you, and don't put everyone into one category. The unsuccessful rate of programs is usually not the person in that program's failure. It's usually to be our own. Okay? Addiction is a brain disorder, and I'm not going to go into that too much. I think for the most part, this is, you know, the Surgeon General has announced it. There's a lot of research coming out. We have new technology that's showing actual live brain scans of how addiction affects the brain. But there's a difference between addiction and physical dependence. Okay? So this is a normal brain. In the memory and the learning part and that part of the primitive brain, that's where those memories of substance use get locked in. Say when someone uses because of trauma, because of stress, because of this, because of some pain that they're trying to cover up, that memory gets locked. When someone gets triggered, the front part, the prefrontal cortex of the brain has been so damaged and maybe not even developed at all if they started very early. And those memories are really strong. So there's no slowdown of, hey, this is a bad decision. Okay. So addiction is a behavior. These are all the things that kind of start happening when you go from use, misuse, and into addiction. Okay. But dependence is something different. The brain has definitely been affected. The brain's job is really just kind of that homeostasis, trying to keep everything normal, trying to keep blood pressure right, trying to keep us alive. And so the biology has changed from more of a crisis state, and that means the dopamine, the endorphins, and all those neurotransmitters have been depleted. So the brain is just trying to keep people from being sick. And so that drug dependence is really just trying to keep from withdrawal. Okay? And you can go through this one. I think I wasted some time. So just to break it down, dopamine is short term. That's that feeling of high. Endorphins is more long term. It's where the memories get locked in and it starts establishing preference. That's where you see people, like I talk to people all the time. I have a group of individuals, and one will say, oh, I like methamphetamine. The other one will say, oh, I hate that. Oh, I like this. Oh, I hate this. Everyone has a unique predisposed chemistry that chooses preference as you use it. And so what is good for one will not be the same. I always hear that people get addicted to methamphetamine on their first use. That's not necessarily true. It's not true. But it does mean that your brain has said, hey, I like that the best. And so it creates more of that pleasure center where the drive is bigger for that substance. Craving is just depletion. It's just your body saying, I don't feel good. Please put some more of whatever that was in your system. Your brain doesn't really know the difference. It doesn't know that it's killing you necessarily. It just knows that that feeling that we had that time fixed the other feeling. Dynorphins is more the long-term reaction of endorphins. they restore through connection. The opposite of addiction is connection. That's why it's really important for every single person that someone comes into contact with in their recovery is someone is trying to create a relationship of hope, of non-judgment, of recovery, because each connection, even brief, I say with doctors, sometimes with nurses, even in the medical community, it may be a brief relationship, but that feeling of hope from that person can create a little trust into the next person that they encounter. Women have special neurotransmitters, men have them too, but this bond that women share, and that's why I think gender-specific programs work so well, is that there's a specific bonding that they go through, okay? You can skip through that. This is my money slide, I guess. This is how I convince legislation sometimes that long-term treatment works. Please stop cutting my programs down more and more. We started 18 months, now we were 12, now we're at 6 months. So this is a healthy person on the left, the brain, where there's lots of activity. Meth use tends and killing all that activity, and people don't react to things the same anymore. But after a little over a year, it's almost back to normal or even improved activity. So we want people to stay in treatment and engage in recovery support longer. Okay? So here's some resources, especially for pregnant women. SAMHSA has come out with these 4 trimesters of what's happening when a woman is pregnant or finds out she's pregnant and is using opioids. It's really good information. If you encounter pregnant women and there's opioid use disorder, I really recommend letting them have these. There's 1 or 2 page pamphlets, and they're free resources. Okay, next. So real quick, I want to talk about pregnancy, especially with the opioid use disorder. The programs that I serve actually accept pregnant women. Pregnant women is actually our priority admission, and I'm going to try to get to that. But what happens is people think that pregnant women are using, they find out they're pregnant and then they start using substances, and that's really not how that works. Someone that's using substances then finds out they're pregnant. And so it's usually in that little window of where addiction has already progressed, maybe into dependence, and then we find out that they're pregnant. The most important time to engage a woman, a pregnant woman, is right there when they're pregnant. Make sure they get all the information that they can. Make sure they have resources in their hand and phone numbers to call. And I'm going to give you some of those too, because pregnant women are motivated for the health of their baby. Whether they're not concerned about their own health, for the most part, pregnant women want a healthy baby. They just don't know how, or they don't have the resources, or they don't have the support. And the worst thing for me in my addiction or my recovery journey was to go and try to get help and have the judgment, the shame, and the further humiliation that I felt in that emergency room whenever I was looked at like what a selfish decision I had made to use substances while I'm pregnant, and it really did not happen that way. Next. So Dr. Mishka Turplin, if anyone has ever heard of him, he's an amazing recovery-oriented physician. I'm not sure how else to put that, but he's done a lot of work around something he calls the 4th trimester. This is after the baby is born, and this is where we start losing women, and this is where it becomes really, really a critical time where now there's 2 changes start occurring, physiological, sleep patterns, everything changes, mental health needs go up, and then the care shifts away from mom to the infant. Pregnancy was all about mom and keeping her healthy, and now it shifts away from her to the infant. Sometimes those resources will be stopped at that time. Say Medicaid gets canceled, no more WIC, maybe not as much food stamps. Things like that really can affect the chance for continued recovery with these moms. Okay? So I'm just going to give some warm and fuzzy data, just because I like data. But just a demonstration of how that time in that 4th trimester, after that is the highest risk of maternal death, is after the baby is born. That is when, as a community, not just a specific professional community, but as a community, we really need to engage and keep these moms engaged and keep checking on them, because it's a very difficult time, especially for a mom that's in maybe early recovery or has limited support. Okay? So SAMHSA has kind of a model for recovery and treatment. It's the core 4 functions are home, health, community, and purpose. That's the things that we strive to achieve while they're in our care. And then those other components are included in a very well-rounded treatment model. So we're looking at many pathways to recovery, not just 12-step, not just spiritual-based, but however that person needs to get there to engage and sustain their recovery. That's how we want to get them there. We involve a lot of peer support. Georgia is a leader in peer support in this country, and we do a lot of work around that. But we have to make sure that we're hooking them up and connecting them to other people with that experience in the community. And always for women, we have to address trauma. The risk for trauma experience goes up for women that use substances. And I'd say 100% of the women in my programs have trauma experience. And some of them don't even realize how severe it is or how much it has impacted them. Okay. So that's just kind of a breakdown of what those look like in a recovery model. Okay, you can go next. So here, recovery is a goal, and this is just for, I don't want to say this is just evidence-based for treatment, but this is kind of the model that we go off of. But I want to say that it's also, it can go across systems. So how you connect with someone that's in front of you, it doesn't matter where you are, can really make a difference. And to be able to provide them, hey, this is the kind of stuff that works. So you need to go into a treatment program, or you need to go to a support group, or, how can I connect you to other things in the community? And so where you work is your community too. I just encourage everyone to, and I can help with that, get to know what treatment programs are out there, get to know what kind of medication-assisted treatment programs are out there, especially for pregnant women with opioid use disorder. We really want to engage them in medication-supported recovery just because that's going to lower their risk to not for just demise of the fetus, because I know that level of risk is really low, but for relapse and return to illicit substances during pregnancy is really high when we aren't getting these women connected to medication-assisted treatment. Okay? So this is, and I've got a couple of minutes, but this is my programs. So I have 21 residential sites, 17 outpatient programs, and 14 transitional housing programs. All the things that I've been discussing, that's what we do there. These programs are all over Georgia, and I'm going to have a list to send out as well. Okay, next. So we offer priority admission. We have federal block grant dollars. We have a contract with the child welfare system. We also have social service block grant dollars and state funds that match, that we give priority admission to pregnant IV using women first, then pregnant women, IV users, defects cases, and so on. And we allow children under the age of 12 to live in the residential unit with mom. So pregnant women, our mandate is to get them in within 48 hours. We do a pretty good job with that, but it is a big state, and so sometimes I've had them in my car. I put them on buses. My provider network is pretty robust, and so we really try to get them put somewhere where they are safe within 48 hours. Okay? This is all of my programs, and I'll make sure that you have these slides. Just a little tip, a little snippet of where they're at and who they are. Okay, next. These are our medication-assisted treatment providers. These are primarily outpatient clinics, but if you'll see that some of the same providers are on this list as well. That just means that they have a waivered doctor, they have some behavioral health, some counseling and treatment options that also include medication-assisted treatment. These are free programs. We have amazing federal grant dollars from the state treatment and state opioid response grant. Hopefully it's been extended for a couple of more years. Hopefully it's going to continue to extend. So right now medications are free in these programs. Okay, next. And you can't read this, I'm sure, but these are addiction recovery support centers. We're trying to open them up all over the state. These are peer-ran, peer-led programs that are operated by certified peer specialists. And these are programs that include, they're kind of like a one-stop shop, one-stop clubhouse. They include 12-step meetings. They include some spiritual foundations. They include financial foundations. Like, they just have a gamut of anything that you could ask for. So if someone is not ready for treatment or they're not saying that they want to do that, then hooking them up with some peer support is really a good option. Okay? I think that these are just some other resources when you can't get someone on the phone sometimes. SAMHSA has a great treatment locator. We have 2 warm lines. One's for mental health, the Mental Health Consumer Network. The other one is from the CARES, which is the Addictive Disease Network. These are just numbers that people can call when they're having a bad day. OTP providers means opiate treatment providers. Those are what you used to call methadone clinics, but now they're much different. They have much different treatment options. And then GCAL is another provider search. Okay, I think that's it. I don't know that I have time for questions.
We do have a few minutes for questions if anyone has them. And thank you. That was a really great presentation.
I feel like I talked really fast, so I apologize.
No. It was great. I think especially it's always good to be reminded of recovery language. I know everyone wants to talk about it in a really compassionate way, and it's so good to be reminded of how to do that. If you have questions, just a reminder, you can press *6 to unmute yourself. I see a question. Yes, you can get a copy of this presentation. I'll send that out. And then also just a comment, enjoyed that, good to know resources.
Good. Yeah, I'm not sure of who's on the call, but it's always, no matter where you're at, a good idea to just have at least your local resources on hand where if, there's someone's in need somewhere. And use me as a resource. If you run into any pregnant women, send them my way. I think I'll make sure my information is on here as well. That is, I don't want to say my personal mission, but it's definitely, right now we have a lot of pregnant women because of the opioid crisis, and that's okay. But yeah, we definitely trying to get them placed as soon as possible.
Let's see, any other questions? Okay, well, we'll go ahead and move on, but Rayanne, thank you.
Thank you.
That was super great. And
thank you. Sorry for the technical problems in the beginning.
No. Don't apologize at all. This was great.
Thank you.
So the next person that we're going to hear from is Shannon Jones. She's a neonatal transport and discharge coordinator at Beverly Knight Olson Children's Hospital and Navicent Health in Macon. She has been at Navicent since 1996 and in the neonatal ICU and transitioned to the transport coordinator role in 2004. She has a real passion for caring for infants who have been exposed to opioids, and she's going to talk to us about how Navicent has been getting their their QI project started, hopefully just to kind of spark ideas and comments from you guys, and just to really kind of spark discussion so that you all can see just how other hospitals have gotten started on this. So Shannon, let me pull up your slides real quick, and you can press *6 to unmute yourself too.
Okay, so can you hear me, Caitlin? Can y'all hear?
Yep, we can hear you.
Okay, good. So as she said, I'm Shannon Jones. I'm actually the Transport and Discharge Coordinator for the neonatal unit here at Beverly Knight Olson's at Navicent. We actually started our journey just by having some really short meetings, emailing back and forth with our team to kind of figure out who we wanted to be on the task force when we decided that we wanted to be a part of this initiative. And so our real first official meeting was not until May. Caitlin, you can probably go on to that first slide. Sorry. I talk almost as fast as Rayanne, so.
I'll try to keep up.
Right now, we are actually meeting every 2 weeks, and probably towards the end of the year we'll slack off and start meeting about every month. But we decided initially that we felt like our labor and delivery staff, all of the mother-baby staff here at Navicent, as well as our NICU staff, really needed to be involved and engaged in part of this QI project, and just because of the different aspects of the way that we deal with those. So we made the expectation that everybody in all of those departments would complete all of the modules. During that initial first couple of meetings, we decided who would be our data persons, who would be our point persons for each department, if there were problems or questions. And Carla Morton is actually kind of overseeing all of it for us. And then our leadership team for NICU, as well as for mother-baby, are kind of the point people within the departments as they are. Before we ever really started into our PI project, our neonatologists and practitioners had already kind of started working on changing our screening processes for the babies that are admitted to NICU, just to kind of minimize the stereotyping. So we've moved, early in the summer, we moved towards all the admissions get a urine drug screen. And then if there's a positive result, then we move towards the meconium screening after that. So you can flip to the next one. Like I said, initially those first few meetings, probably from April to May, the first part of June, we really were just kind of talking about what our thoughts and ideas were, thinking about what our challenges could possibly be and goals that we wanted related to the initiative. We wanted really, probably the hardest one I think for all of us is probably just staff buy-in and participation, and then changing the perceptions and the culture that we have of judgment, and not necessarily thinking of them as a person but as that addiction. The other challenge that we feel like we would be the MD buy-in, not just from the pediatricians and the neonatologists, but from the OB side as well, and their willingness to support and change practices, you know, if that was something down the road that we found. Inconsistencies in practices from just the general practices that we have here in our area, our staff OB, our MFMs, as well as the private pediatricians, our staff pediatricians here within the hospital, and the multitude of residents that we have in both practices, and then our neonatologists. One of the other things that really was probably a big challenge for us is if we move towards trying to keep mom and baby together, which we know is ideally what the goal should be, how would we do that without an option of them rooming in with our NICU as not a private NICU, so they aren't allowed to sleep at the bedsides, and we don't really have nesting rooms available for those moms out on our maternal side. So that was one of the big things that we've kind of talked about, and moving forward, how will we accommodate that, trying to keep those moms and babies together. So just kind of looking at the short list of things that we've kind of really worked on hard over the last few months as a task force. Just from June and July, our main focuses really were looking at our timeline for completing the modules, and we decided that we would go along with how they have it set up on the GaPQC website. So that way it was just easier for us to be able to keep up as well. We've started adding abstinence education early on with our new orientees that are coming in for NICU. Typically, we were doing it 6 months or a little further into their orientation, but now we've really started trying to focus on getting it in early as much as we can. And we're adding it to our annual competency requirements. So hopefully we will see some improvement in the reliability of our scoring and just really people understanding what those definitions are. We are working currently on a parent education handout for infants that are suffering from NAS symptoms, for those parents, for mom, so we can really kind of bring them more into helping us as far as what the plan of care is going to be, help them understand what our goals are, and really kind of incorporating them into the hospital stay, whether it's just for a few days for monitoring or whether it's long-term until we can get the length of stays down. For August and September, we set up a lunch and learn with Rayanne and some of her, a CARES counselor, and I don't remember the lady that was from Northeast Georgia, but they all came down and we had like a little 4-hour lunch and learn just to bring some information and some insight. Most of us had heard them speak at the Quality Initiative back earlier in the spring, and so we really wanted to bring her and some of those resources here so we could hopefully start changing some of the mindset of some of our staff. We sent that out to some of our regional centers, or to all the regional centers, as well as the referring hospitals in our area, and we had a pretty good turnout for that. So I think the more that we can bring those people with that lived experience and expose them to other people, the better opportunity that we'll have to kind of change those mindsets. We did get to offer CEUs to the participants who came for that, so that was kind of a good motivator, I think, for some of the staff here. And then we really just decided probably towards the middle to end of September at our meetings that NICU would be our main focus right now, because typically all of our babies that are exposed or that are showing signs of abstinence and withdrawal, they will actually come to the NICU. So we felt like initially that focus really probably should be over here with us. So you can move. Just some of our goals that we've kind of set for October. We'll be putting some laminated guides at the bedsides for our nurses to try to help improve our scoring that has the definitions and that sort of thing on it. So hopefully we'll see some improvement with that. We're still going to do some more intensive training as far as the Finnegan scoring and inter-rater reliability and that sort of thing. But hopefully having these guides at the bedsides is going to help as well. We're just kind of going back and looking retrospectively at some of the positive drug screens that we've had since we started doing those on admission, and then reviewing the maternal record if we have it available to see would those have been babies that we would have missed on the maternal side with mom not being screened. And then the other thing that our NEOs are working on now with our practitioners is really establishing more of a consistent timing for the scoring just kind of going back and looking through, our nursing staff is kind of all over the place with when they're looking at their scoring and when they're scoring these kids, and so we really want it to be consistent across the board. So for some of our accomplishments, all of our staff were registered initially to start doing the VON modules, and for our NICU staff here, around 84 to 85% of them are already on target with us and kind of what the goals and the timelines were. And then some of them are even actually ahead of us on the timeline. So they've actually been a little, they've been a lot more go-getter with this initiative than probably with anything else that we've done in the past. So I think we've got a lot more buy-in than we originally thought we would have. Our educators tracking that probably every 2 weeks and just sending reminders to the nurses by email. She's also putting reminders in our weekly news for what modules that are due and when they're due. We've now got a quality member on board with us. Several of the staff from the quality department have actually emailed Carla and are starting to complete the modules as well. So they'll be coming on board with the task force with us too. We've had a lot of positive feedback from the Lunch and Learn. Like I said, it was just like a little 4-hour Lunch and Learn. We had about 40 participants, I think, who were able to come. And I think just, again, being able to hear from people who've lived that experience with the staff from Northeast Georgia kind of talking about what their challenges were and that sort of thing. I feel like it's probably going to help all of us in the long run. But they provided a lot of resources for us and contacts that were in our area that we really, I don't think without them would have known that are available for these moms that are here in our communities. Okay. Some of the challenges still ahead, like I said, I think these are probably across the board for all of us as we move through this initiative. But just getting pediatrician engagement, again, whether it's our private pediatricians or our staff peds, just really getting them more involved in our initiative. The OB providers as well. Changing the changes in our staffing issues are really kind of limiting participation from the OB side and the bedside clinicians in our mother and baby unit right now. So hopefully really bringing them back on board more consistently. Inconsistencies in practices, both maternal and neonatal, as far as what their screening criteria is and that sort of thing. Changing the culture, like I said, I think is probably one of the biggest ones and probably the most challenging one. Will be changing the culture. We all come with our own kind of perceptions and biases, and that's a hard thing to change a lot of times. We really want to try to engage and involve DFACs more. They have the actual, resources available to help us put these moms in contact with the resources that they need to provide those moms with resources so they can maintain a sober lifestyle and a healthy pregnancy. Again, the resources in our referral areas and just trying to get these moms during that pregnancy, early in that pregnancy if possible, and how can we get the OBs connected with these resources so that they can help these moms prior to delivery. We really thought about, with the moms and stuff, we have a pediatric EC now, and the moms that are potentially missed or babies that are potentially missed that are coming back into our EC with, 7 to 10 days later with poor feeding, irritability, not really any other more specific symptomology, but then coming back in through the EC, are these babies that were missed after delivery, and are they now coming back in, and having our pediatric staff, whether it's on the general peds floor or whether it's our peds EC staff, kind of looking back and thinking through, is this a baby that potentially is now having effects of withdrawal? Again, improving our NAS scoring and just the reliability of it, again, it's all over the place for us. So that's one of our big goals. And then establishing protocols for both us and for mother baby. Right now, it's just kind of a toss-up for us, depending upon who the physician is and what the baby's score was. So hopefully if we can get some protocols established that it'll be a little bit better for the babies and more consistent. And then the last thing is just really providing that consistent care and education and support for the babies and their moms and families, and trying to get them connected to the resources where they can maintain.
That was great, Shannon. Thank you for giving that overview. Y'all have really gotten to a great start over at Navicent. There is one question in the chat. I can read it out in case people can't see it. It says, do you find it challenging to get a good urine specimen in a timely manner on all babies? We've been screening all moms for about 21 months, interested in results with screening babies instead.
We really have not gone back and looked at the numbers quite yet. We started this, I think, in July. I'll have to go back, but I believe it was July that we started, June or July. So we've really not looked at that. Typically, we don't really have a problem getting urine specimens on these babies. You know, initially I think we talked about maybe doing both, but decided on just going with the urine because I think a lot of times we have a harder time getting meconium specimens than we do urine specimens on these babies.
Okay, and then there's one more. Can we get a copy of your bedside guides for scoring?
Yes, we can get that, and I'll send that to you for you to send out.
Yeah, I'm happy to send that to the group.
Okay.
Are there any other questions? A reminder, you can press *6 to unmute yourself if you don't want to use the chat box. And also questions, or are there just any other, kind of successes or challenges that that any teams are having and want to share with the group? And I see another comment. Great work. Thanks for sharing.
Dr. Levine, that is great work. Could you comment further on, maybe I missed it, on how you're dealing with the challenge of keeping moms and babies together since you don't have nesting?
Right now, we are still struggling with that. We've talked about hopefully being able to utilize our pediatric floor since our NICU has now moved over here, being able to keep mom and baby together on the pediatric floor. Again, our biggest challenge has just really been not having the resources to be able to keep them together. Mm-hmm. And then, again, not really having, being able to keep them here in the NICU. So moving forward, our goal is to hopefully incorporate them and keep them over on our pediatric floor.
A lot of folks are doing that.
Right. That's what we're hopeful for.
Congratulations on getting so much of your staff through the modules. That's wonderful.
I think the fact that we're offering they're actually using that as kind of a motivator for them. They can use it as part of their annual CEUs that they're required to submit. We're allowing them to use some of those CEUs from those modules. So I think that has helped us in getting them motivated to doing it.
And one thing I'll just brag on about Navicent too is I think that they have the most people enrolled in the Vaughn lessons So it's kudos to them for getting that many people so far along in the lessons. It's been fun to see that come in every month. Okay, well, while we see if any other questions, well, I guess I do see in the chat box too other people having issues figuring out how to keep moms and infants together. So let's keep that in mind as something to continue sharing about on these calls. If you have ideas for how your hospital has been working on that, that would be a great thing to share with the collaborative. But the only reminders that I have are we did set up a kind of technical assistance call next Wednesday, and Dr. Patel, you should be familiar with him. He's presented on these calls before. He's going to be available to answer any questions that you have if you're struggling with where to get started, or if you have kind of more specific questions. He's a great resource and will be able to answer anything that you have. He's also really knowledgeable in QI, so particularly if you want to kind of walk through your SMART aim or your key driver diagram, or if there's any additional measures that your hospital is wanting to track, this would be a great forum for that too. So just remember that, and if you think of questions beforehand, you're welcome to send those in. Yes.
Can you hear me?
Yes.
This is Rayanne. I want to add one thing. So the idea of culture change, and I'm in the car now, so I know it sounds awful, but the idea of culture change is really, I know, is a big challenge. I was recently in a hospital in Athens and visiting a friend, and they had these little signs that say a person struggling with substance use is a person too. Just little signs everywhere. You could tell it was for the staff to see, but it was interesting. I had to take pictures of it. I couldn't believe it because it was all the things that I have preached about and tried to teach, but it was this hospital that was kind of embracing it and putting these little messages everywhere so that if someone is struggling with substance use and they feel like they can't bring it up to their physician or to their nurse, that they were saying it is okay, we understand. So I really appreciate Navicent's effort in that, trying to change that culture. I know there's many hospitals doing it, but I just thought that was the coolest thing. There were this cards and posters kind of scattered around that said recovery is real and we believe in recovery, and so just that message alone could really change the way your patients feel, and if they bring up to you, yes, I might need some help. So just a thought. But great work, Navicent. I love talking to you guys.
That's a great tip. Thank you. Okay, well, it's just about 2, so we can go ahead and end the call. Yeah, just a reminder, if you think of questions before that call next week, feel free to send them in ahead of time. If not, that's perfectly okay. We can answer them on the spot too. But thank you very much to our presenters, and thanks to everyone else for being on the call today.